Hello, hello. Good afternoon to everyone. My name is Melissa Molina Trinidad. I am the founder and president of the NALHE Tri-State Chapter. It gives me great pleasure to welcome you to our Fostering Inclusive Care for the Latinx LGBTQI+ community. If you're new to the NALHE family, I'd like to take a few minutes to share with you highlights of our professional association. NALHE is an organization that began in 2005. Our mission is to promote health equity for Latino communities by increasing Latino and Latina representation within healthcare systems and by supporting policy, legislation, and regulation that seeks to improve health and healthcare for diverse communities. Our vision sets the runway for our future to be the professional association of choice that transforms the Latino and Latina experience in a national healthcare leadership space. We promote and practice authentic leadership, being genuine, self-aware, and transparent. We want you to be inspired by the loyalty and trust. We champion diversity, equity, and inclusion initiatives. We advance various perspectives and ideas, and we strive to work diligently to position you to have a role, a voice, and a seat at the leadership table. The NALHE footprint spans across the US via multiple chapters. Our growing members and partner networks represent students, early careerists, mid to senior level executives, physicians, nurses, and other industry professionals that seek to connect and share best practices. We welcome you to connect with NALHE and the other NALHE chapters listed on our website at www.nalhe.org. And we also invite you to think about starting a NALHE chapter in your region if one does not exist today. At NALHE, we're really proud and thankful to have multiple health industry partners and sponsors such as Hartford Healthcare in Connecticut, which happens to be our chapter's direct sponsor. In these partnerships is key to ensuring that together we can work across market and competitive boundaries and have core values and a unifying priority to create inclusive opportunities. We welcome a connection with your organization to consider sponsoring future NALHE events. So today we are convened because we're celebrating Pride Month. I'd like to thank and recognize our Programming and Events Chapter Board and committee members for giving emphasis to this critical topic. Thank you for your servant leadership, multiple volunteer hours, and for designing and launching today's activities. With that, enjoy the presentation. My best wishes to all of our attendees, partners, and members of the NALHE family. Thank you for joining us, and I'd like to now invite to this virtual stage my Treasury Board member, Gabriel Paz Larach, your moderator for tonight. The stage is yours.
Thank you, Melissa, and good evening, everyone. Happy Pride. My name is Gabriel Paz Larach, and I'm the treasurer of NALHE's Tri-State Chapter. I'm also a business strategy consultant with experience in advising healthcare organizations in matters of patient engagement and operations. It gives me great pleasure to welcome you to our webinar, Fostering Inclusive Care for the Latinx LGBTQIA+ community. It's a little bit of a mouthful, to culminate Pride Month. We have the honor of hosting Dr. Samantha Corby, a family nurse practitioner at All Care Medical and lecturer at the Yale School of Nursing, and Cesar Quiñones, an advocate for transgender health. I'll properly introduce Dr. Corby and Cesar once we begin the panel discussion, but thank you so much to both in advance for your time and for your insight. So in the next hour, we're going to present an overview of current progress and disparities in LGBTQIA+ healthcare, particularly for Latinx communities, and have a moderated discussion with Dr. Corby and Cesar here, where I will ask them questions pertaining to the topic of inclusive care for LGBTQIA individuals, including those identifying as Latinx, and their differing perspectives on it. Towards the end of the discussion, we'll open the room for questions from the audience. So why are we hosting this event? Today, in commemoration of Pride Month, we're hosting this webinar to have a conversation about LGBTQIA healthcare, which has made advances over the years, but still has a long ways to go from an equity and access standpoint, particularly for those in communities of color. As you might all be aware, the LGBTQIA community faces greater health challenges than heterosexual individuals. This is due to a combination of the following. One, differences in sexual behavior and the disproportionate rate at which diseases like HIV/AIDS impact the community. And secondly, social and structural inequities, like the stigma and discrimination that come as a result. We're aware that a conversation around LGBTQ healthcare and the added layer of intersectionality make this topic a complex and nuanced one that can't be covered in its entirety within an hour. So think of this webinar as an introduction to the topic with perspectives from an expert in the field and an advocate with lived experience as a trans man. So the past few decades haven't gone by without some progress achieved. Among some highlights, we find, for example, that the World Health Organization removed homosexuality from the International Classification of Diseases in 1990. Or conversion therapies aimed at changing sexual orientation have been banned in 20 states, although there was no state law or policy in at least 26 of them. Or another example is advances in antiretroviral therapy like PrEP and PEP, which have significantly decelerated the spread of HIV/AIDS. Although there have been advances, however, to narrow the equity gap for LGBTQ individuals in healthcare, there is still much more to be done. We still see a lot of discrimination, a lot of disparities and threats that exist that threaten the idea of LGBT healthcare, equity and equality. One recent one, as we all know, in the past week has been the overturning of Roe v. Wade, which puts marginalized communities that are most in need, tend to be most in need of abortion care. It puts them at risk and threatens other LGBTQIA rights like marriage equality. 29% of trans Americans have been refused care because of their gender identity. 15% of LGBT individuals have avoided medical treatment due to discrimination. 30% of individuals face difficulties in the last year accessing necessary care. 1 in 3 transgender individuals had to teach their doctor about trans identity in order to receive appropriate care. At the state level, there's about 27 states that have no laws providing insurance protections for trans individuals, 26 states that have no laws banning conversion therapy, and 4 states that have banned or restricted access to medically necessary best practice gender affirming care for trans youth. These are just some of the statistics. There's plenty more that basically illustrate that the very existence of LGBT healthcare is still on the balance. And the implications of all this are pretty severe. Discrimination and even the potential for discrimination can deter LGBT people from seeking care in the first place. And structural barriers limit their ability to do so. Factors like low rates of health insurance coverage, high rates of stress due to systematic harassment and discrimination, and a lack of cultural competency in the healthcare system leave LGBT people at a higher risk for cancer, mental illnesses, and other diseases, and make them more likely to smoke, drink alcohol, use drugs, and engage in other high-risk behavior. So when looking into the statistics for Latinx and other individuals that identify as LGBT, the disparities are even more staggering. So, for example, 42% of LGBT individuals or adults identify as people of color, including 21% who identify as Latinx. Trans women, Black and Latinx men have the highest risk for HIV infection. 1 in 10 Latinx trans people are HIV positive. 23% of Latinx trans people reported being refused medical care due to bias. Over half of LGBT Latinx individuals have health insurance coverage compared to 77% and 82% of the heterosexual adult population. So the reasons for these disparities like these vary and encompass different cultural and behavioral barriers. One being obviously the limited English proficiency. So Spanish speakers account for nearly 2/3 of all limited English proficient individuals in the US. And while the National Standards for Culturally and Linguistically Appropriate Services in Healthcare has issued recommendations for culturally competent care, interpreter services, and organizational support, it's unclear how adherent health systems are to these regulations. The lack of an open communication between these patients and health providers may prevent information sharing, such as the disclosure of gender identity and sexual orientation, and or deliberation about treatment options. There's also documentation status. According to the Williams Institute, about 70% of undocumented LGBT adults are Latinx. As a result, many undocumented Latinx LGBT patients experience additional barriers that prevent them from accessing medical care and building trusting relationships with providers. So these fears like barriers like fear of deportation, not wanting to disclose their immigration status, and the inability to take days off from work can reduce opportunities for these patients to engage in high quality communication with their providers. There's also religious beliefs. Latinx LGBT patients tend to have strong religious ties, and they may experience like a cognitive dissonance between their faith and their identity. So that really can affect the disclosure of their sexual orientation and gender identity to providers whom they perceive to be religious. There's also the family stigma and social support. So among LGBT Latinx individuals, there also tends to be strong family connections and friend networks that are associated with a positive sense of self. And when LGBT patients are making medical decisions on their own without the family support that they may prefer to have, it tends to decrease their self-reliance and increase their reliance on providers in the decision-making process when they don't have that family support. Then there's also traditional expectations of masculinity. I think that's pretty self-explanatory. Machismo permeates across Latin American culture, and identifying as gay, for example, may not be acceptable within the culture because of stereotype perceptions about gay men being quote unquote less masculine. There's also the traditional perception of the patient-doctor relationship. Latinx patients often perceive that the patient-doctor relationship is paternalistic, so they may be concerned that asking questions and seeking advice related to LGBT health may affect their relationship with their providers adversely. And lastly, there's also the fact that there's diversity among the Latinx LGBT population. Although many Latinos share core cultural values, cisgenians aren't often aware of the significant diversity and heterogeneity among this population in terms of countries of origin, religious beliefs, educational attainment, acculturation, etc. So providers can still fail to understand the differences among these different subgroups. So all this is why representation matters in healthcare, in all fields, but in healthcare because that's what we're here to talk about. Having providers who identify as LGBTQIA and or Latinx and understand the particular sensibilities of these communities can make a significant difference for patients who lie at the intersection when seeking medical care. And on that note, we've invited Dr. Samantha Corby and Cesar Quiñones to share their perspectives. So let me give a brief introduction. Dr. Samantha Corby was born and raised in Salem, in New Hampshire. She did her undergraduate degree in psychology at Boston College. From there, she received a master's in behavioral neuroscience from the University of Connecticut and later received her Master of Science in Nursing with honors and Doctor of Nursing Practice from Yale. She's board certified in family practice from the American Nurse Credentialing Center and a member of the American Association of Nurse Practitioners. She's also done an extensive scholarly work in the topic of inclusive care, particularly for the LGBTQ community. She's fluent in Italian, has a black belt in karate, and formerly worked as a professional opera singer around the US and Italy. And besides LGBTQ healthcare, her passions include travel, good food, and her dog Woody. When she's in at work, she can be found spending time with her wife Sarah in Salem or at their house in New Haven. Then we also have Cesar Quiñones, who's a proud and passionate neurodivergent trans man of color. He graduated from Kingborough Community College with an associate degree in liberal arts and worked in a variety of customer service and logistics roles. Throughout his transition, he overcame hardship and discrimination in both medical and professional settings, which inspired him to advocate for other people of color facing similar struggles of his own. I'll be asking Dr. Corby and Cesar some questions to get insights and share their experience, and then I'll open up the forum for questions from the audience. So, hi, Dr. Corby. Hi, Cesar. Thank you so much for being here. Let me start with you, Dr. Corby. We'd love to hear what drove you to specialize in LGBT healthcare.
Sure. Hi. Thank you so much for having me. I'm honored to be here. So first and foremost, my own personal experience drove me towards it. I can be confident and out and, easily talk about, the fact that I have a wife now. But, when I was younger and I would go to the doctors, I would absolutely hide it and I would not talk about it. And I would use fancy language, talk about, my significant other, or maybe even call them my boyfriend or whatever, just so that I didn't have to deal with the confrontation of what might happen. So personal experience kind of started it. And then when I was first in nursing school, we had to do an assignment on an issue in nursing. And I chose to pick looking into healthcare disparities for the LGBTQIA plus community. And I found this incredible, it was this huge disparity and there was just so much to get into what was like a 5-page paper at the time or something. And, from there, Yale decided to offer a gender and sexuality health justice concentration. So I did that and that blew my mind. And then I decided on my doctoral work to just take a really deep dive and just found there is so much that can be done, but that needs to be done, but really incrementally, we can start attacking it in really useful and concrete ways. And that's kind of where my doctoral work took me. And I'm excited to kind of spread that message now.
Oh, that's great. I know it's great to hear about your own personal experience and how it led you to engage in this work. I know for me, this topic is also personal, just given that I'm also I'm a gay man and I've worked in the healthcare space. And as a Latino in particular, it also, it's close to home. And I know that I felt also like that kind of hesitation when I visited healthcare providers in the past about disclosing my sexual orientation just because of fear of stigma, discrimination,
Absolutely.
and
Absolutely.
the like. Yeah. And given your work, why do you think that it's important for providers, or why do you think inclusion and intersectionality in healthcare when delivering care, why are they important?
So this is a huge question. And yes, it is so important. Let's start with, the intersectionality portion of it. So humans are multifaceted and humans are never just one thing. And when you start to think about different marginalized identities impacting and compounding upon one another, that person is set up for more and more disparities, specifically in healthcare. So to think about it for a second, what does it mean to be, say, a woman in the United States right now, which is a little bit of a loaded question, right? Given some of your intro, right? But what does it mean to be a woman? Okay, now let's think about what does it mean to be, let's say, a Latinx woman, right? Okay, then let's think about what does it mean to be a queer Latinx woman, right? And as we keep adding all of these levels onto this one person, right? And let's just say the pronouns that this person uses is she, whatever she is looking for in healthcare or needs in healthcare is going to be different than the next person, but we need people that are experienced and culturally competent in those different levels, because it's really not one size fits all. It truly isn't. The healthcare disparities that face transgender women are different than the healthcare disparities that face gay men, are different than the healthcare disparities that face non-binary people. And so it's so important that healthcare addresses all of these different layers, so that, we can start to provide a more inclusive care, a more culturally competent care. Now, what was the first part of your question? I want to make sure I'm answering the whole thing. I addressed the intersectionality.
It was about inclusion and intersectionality, which those, are woven together, basically.
Yeah, it's so important that we recognize the different layers, even in terms of what you said before. There's cultural layers, there's economic layers, there's religious layers. And it's so important that we are communicating, and healthcare institutions are communicating to our patients that they're in a safe and welcoming space. Because with all those different layers and all those filters that people are navigating the world with, you can't leave it up to chance that they guess that you're a safe space. Right? Absolutely. Because everybody's coming at things from such a different perspective, even two people in the same family, right? So being open and being very clear about where you and your clinic stand is already going to put you and your clinic at a leg up.
Absolutely. And Cesar, you obviously come at it from more of a patient perspective, right? Having gone through your transition. And I just kind of want to ask you the same question. Why do you think, having had your experience, why do you think inclusion and intersectionality when it comes to a provider giving you care, why is that important to you?
Like Dr. Corby was saying, everybody has different parts of our identity. No person comes from the same narrative, and it's important to be informed about all different type of people that are going to come to you. And I think especially LGBTQ people, especially LGBTQ people of color, they're in a very sensitive spot, and they more than likely have come to face with discrimination in multiple forms, whether that be due to, ignorance or just being bigoted. It's important for people to be knowledgeable so we can include everybody and everybody can feel safe.
Absolutely. And Dr. Corby, because obviously you've specialized in LGBTQ healthcare, and I'm sure you've kind of seen the gamut of patients, because obviously there's a lot of diversity within the community, right? In all senses. Have you seen particular differences in how LGBT patients across these different demographics, especially those that are from communities of color, and how they're treated?
So,
and if so, what are some examples?
So one of the big places that you see a difference is that the people that are coming from more religious communities, about a real fear. And it really depends on how big the clinic or the town you're working in can be. So one example of a person who, was really afraid to come out to their providers in the clinic because it was a small town. And well, could they trust, they're thinking, can I trust that this front desk person isn't gonna, gossip to the person at the grocery store on the weekend, right? The small town mentality is a real thing. And so that's an example of why training needs to be done to truly understand how sacredly important this confidentiality needs to be within the clinic. Other examples that I've experienced are people who come from really religious communities. Every religion has its people that are more liberal with it and people that are more strict with it. I have had experience with a very decently large Latinx Jehovah's Witness community. And the LGBT members of these families have been ostracized or at the very least, you do not talk about it, and it is an absolute separation of their life and their family life and their personal life. These are the kinds of people that are going to guard that information so much more deeply and so much more carefully. In terms of their treatment at the clinic, I think the providers around me are afraid to not be nice, right? So I haven't personally seen any outward discrimination, but that being said, there are so many studies out there that it absolutely does happen. Not even just discrimination, but outright abuse sometimes. I mean, the transgender community has suffered abuse at the hands of their providers who have been afraid to touch them. Or have been very rough physically with them. The intersex community has experienced people gape and jaws drop and things like that, and it's awful what people have gone through. Even the asexual community has gone through a pathologization of their sexuality, as if something is wrong with them that they feel this way. Now, these aren't specifically Latinx examples, I'm aware. The examples that I have encountered personally have been the more self-imposed, as in the individuals are keeping themselves from disclosing information to us, which is it's so hard to provide good care if you don't know the risk factors that you need to be screening for, right? So so those would be the major examples that I've experienced with the Latinx community thus far.
Right. No, I appreciate that. And Cesar, just given your experience, and I'm sure, and I know that you've overcome a lot of hardship and discrimination, right, at work in matters of your health care. And I know this is a sensitive topic, but if you feel anything that you want to share with regards to that experience, just wanted to give you the space. If there's anything that you've experienced where you feel like you were mistreated, what happened, and what do you think the provider could have done a better job at?
Well, first, the first thing I'm going to share is not specifically in a healthcare setting, but in generally speaking, I've had superiors at jobs. I've worked in food service, and I've always had to advocate for myself and educate people around me, to have people understand me. And not everybody was always receptive, but essentially I've gone my whole journey advocating for myself, because even in New York City, nobody was involved, and especially for trans men, nobody was informed, I'm sorry. And especially for trans men, we have essentially no representation. I've gone through movies, I've gone through books, I've gone through every sort of media that people consume, and I've had to dig through it to find representation. And even then, there's not a lot of representation for trans people of color. It's very tough to feel like you're normal when you have society throwing things in your face all the time about, how you're going to go to hell, or you're a perversion, or all these negative things. And it just makes you have to have a really strong sense of self to be able to pull through all that and come out better in the end, because you can come out stronger. Particularly in healthcare, the same thing. I've had to inform the people around me. And even if the healthcare provider was informed, usually there's a lot of staff in the office, and especially a lot of younger staff that even though they're younger, they're oftentimes they're just there working a job, and they don't have as much education as the providers. And so people in the allied health fields, there's not as informed. There's the providers, somebody at the front desk may or may not know how how to approach the conversation. And more than that, it's like the infrastructure, so to speak. Like when I sign in, there's not really any accurate thing for me to indicate like my name is this. And especially, I'm sorry, especially as a person on the spectrum, which is quite frequent, I found with trans men. A lot of them are like, a lot of people that I know that are trans men are on the spectrum. And they have chronic illnesses too. But we're on the spectrum. It's just, no, you have to constantly advocate for yourself. And
Right.
it's exhausting sometimes. It really is.
Right. No, I definitely appreciate that. And, you know, Dr. Corby, based on what Cesar just said, how do you think, because it definitely is kind of like an organizational issue where it doesn't, the burden should fall on the healthcare organization in general. It shouldn't necessarily just fall on an individual provider, right, within the organization.
Absolutely.
So how can organizations implement efforts, or what are efforts that could be implemented to make sure that you know, individuals in these circumstances just feel comfortable and feel like they are in an environment where they can trust the people who are giving them care?
So this is a huge part of it. It's absolutely, Cesar, you're absolutely right. It's not just the provider, it's the entire team. And you may have a provider that's the most inclusive and amazing and affirming and supportive, but then you get out to the front desk and they misgender you, and they call you by your old name, and they completely throw everything out the window, because for a lot of transgender individuals, for example, the insurance card has to be the legal name, and if the name hasn't been legally changed, it has to stay that way. And things like laboratory reports have to have the legal name on them. So there is a bit of a dance that has to happen with making sure you remember to use the correct name and the proper pronouns. So it is absolutely essential that the entire team from the top down goes through training. And training at the very least in terminology, okay, LGBTQIA plus terminology, gender neutral language, okay, practice with correct pronouns and preferred names, okay, training in implicit bias and microaggressions. Those are the bare minimum trainings that everybody from the front desk to the medical assistants to the billing office to the CEO should have training in. Beyond that, there can be specialized training. So the medical team and the providers can have training on specific healthcare disparities. And actually, I take it back. Everyone should also be trained in the healthcare disparities. Everybody needs to know that. Beyond that, the providers can be trained in risk factors, for example, certain physical exams, alternatives to physical exams, things like that. The front desk is the face of the office. And it's exactly what Cesar said. We have to implement inclusive intake forms. The intake forms have to ask. They really, truly need to ask. So legal name is important. We need to know what that is for legal reasons. But right next to that needs to be preferred name and correct pronouns. And notice I don't say preferred pronouns, it's correct pronouns, okay? That's a really important way to communicate to your patients that we know this isn't a preference. This is who you are, okay?
Right.
So correct pronouns, sex assigned at birth is important to know, because people who are transgender, for example, go through all different kinds of transitions. Some are social transitions, some are physical transitions, some are any kind of level along the spectrum of the transition, and it doesn't make their transition any more or less valid. But when you're in a medical setting, it is helpful to know physically what body parts a person has. So knowing sex assigned at birth is important. Knowing partner status is also helpful. And having lots of different options for people to say, I'm partnered, I'm married, I'm engaged. understanding what someone's sexual orientation is, so understanding what someone's gender identity is, having many different options to select, and then also not using the term other to check. We don't like the term other anymore. Just something else with an entry that they can write in what their identity is, because there's a plethora of identities that can't be just put on a little intake form. These basically 6 different areas that you are very easy to squeeze onto an intake form communicate volumes to patients that they're in a safe place, or at least starting to indicate that they're in a safe place. And that the information is so useful to be and then incorporated into the EMR. And then from there, there's more trainings obviously that need to be done, but it's top down. Everybody has to have it. Everybody has to have it. And even what you say, Cesar, the new people that come in, that it's just a job for them. In my clinic, everyone gets the trainings. I don't care if you're going to show up and work for 2 weeks and then leave. You're going to get the trainings, right? That's an absolute, no questions asked has to happen when you come work for us.
Yeah, no, absolutely. And Cesar, just to maybe dig a little deeper, like what are specific pain points or key pain points that you face when you visit a provider? What are those pain points that you face that really keep you from feeling comfortable in that care environment? What helps you trust that provider?
I think it really, from when I enter and, when I'm taking I think from the beginning, when I'm first taking that intake form to the interaction at the front desk, I often have to feel out a place to see, okay, do these people at the front seem informed? And then I have to go off the, intake form. Is there proper spaces for me? Like, is the language here correct? And I see a lot more places are, trying to be more inclusive. They don't always hit the mark, but it's opening up in a lot more places. And, I've been pleasantly surprised. Sometimes I expect the worst, but I've been pleasantly surprised. And I think also the way a lot of providers I've been to, particularly in like private practices, because that's what I grew up going to, private practices. And that really shaped my experience, because I think like I felt that, that's what was that was what going to a doctor was like, or, just any medical setting. I had a lot of older white male doctors, and they kind of instilled a fear in me that in the back of my mind, I think, okay, well, are they going to be racist? Are they going to be transphobic? It's just a constant checklist and a system of checks to see, okay, do I feel comfortable here? Because I think, especially, as somebody who's on the spectrum, and, it's coming up a lot that a lot more trans men are starting to realize, hey, wait, I'm on the spectrum too. And, I don't know, I'm not a medical professional. I don't know the reason, but that's also factored, a part that has to be factored into the care that I think is not focused on at all. I had to dig through medical journals to find this. I was informed by the people around me. So it's just a lot of little experiences, that add up and really shape how you view the medical system. And lastly, after I transitioned, I was very hesitant for a long time to schedule any doctor's appointments. Like, I didn't go to the doctor of any type at all for at least a year, because I was just so afraid. I didn't want to go through that experience all over again. But fortunately, I found, some supportive places, and I have a primary care provider now.
Yeah. I'm sorry you went through that. And was your fear coming from you had like just a bad experience going through the transition with the provider in terms of how they were treating you, or was it just was it something else?
Sorry, at the most unfortunate time, I'm receiving so many calls and I'm hanging them up. But oh my God, I'm so sorry.
Oh, no worries. No worries. If you need time, I can
Yeah, I'm
relay
sorry,
over
just
to.
give me 1 moment.
Okay. Actually, Dr. Corby.
Could you repeat the question?
Oh yeah. My question was, you obviously you spoke about being fearful post-transition to go to a provider, right, for about a year. And I was just curious if the fear was coming from a bad experience that you had with a provider or team of providers that were giving you care throughout your transition, or was it something else where that fear was stemming from?
It has been both. I haven't had any provider that was outwardly, discriminatory towards me, but I have been to countless clinics where, I've been misgendered. I've had my dead name called out, and the instances that I have faced discrimination in general, but that was mostly in a professional or even a home setting, like not discrimination, but like bad attitudes and like just the first, I think for most trans people, the first formative negative experiences happen at home. And then that's later solidified in healthcare because there's just not a lot of knowledge. There's an extreme lack of knowledge. And they just, even from their own family, like I think you heard the message, my grandma yelling for me, I still get dead named on a daily basis by family members. So it's very, you have to be able to, take a lot of hits and not take it to heart, because most people are going to mess up, whether it's intentional or not. Right.
Could I make a quick comment on something Cesar said?
Absolutely.
I'm so glad that you brought up the whole part about private practice being a place where you didn't feel very safe. And in the research that I did, that's what I found. It's mostly FQHC and university healthcare centers that have really put these initiatives forward. But as you get down to the smaller and smaller practices, which are providing care in many and most communities outside of cities, people are clueless by and large. And so my doctoral work has been how to adapt these models for these larger institutions to a smaller scale, to make them, an inclusive healthcare model more attainable in a small practice. My practice isn't big. It's 4 doctors and me. So 4 medical doctors and me and APRN. We're not big. And it's people that have been practicing for 30 years and really set in their ways. And, it took some work to educate them. But now we're providing inclusive care. And we're a place in New Hampshire, so people don't have to go to Boston, or people don't have to go to Dartmouth Hitchcock. They can get their care right in Salem, New Hampshire. So it's my hope that we can use this kind of adapted model, which is not very hard. Talking about trainings before, I think everybody in the office went through 1.5 hours to 2 hours of trainings. It doesn't take that much. And then they have resources that they can reference and whatnot, but it's not that heavy of a lift. It just, you need to have the desire to do it. But that's my goal, is to get those private practices, much more inclusive and culturally competent.
Can you actually speak a little bit more to how you adjust that model? Would love to hear.
Yeah, absolutely. So there's like 3 basic areas where that need adjustment. One we already talked about was the intake form. That's a huge one. And what goes along with that is like the physical and digital infrastructure of your clinic. So what does your waiting room look like? Are there posters everywhere, and are they all cisgender and heteronormative? Do you have any imagery of anything other than a heterosexual couple that looks like a heterosexual couple? Do you have magazines that are inclusive? Do you have any decals on the doorway outside that show that you're inclusive? Are your bathrooms gender neutral? So in our office, we only have single stall bathrooms. So technically they were all gender neutral, but we put a gender neutral sign on there because it communicates something, right? So, you know, signage is huge. The website is huge. These are just little adjustments. It doesn't have to be plastered with imagery. Just a few things are really important. A non-discrimination sign that clearly states that you do not discriminate based on race, sexual identity, gender identity, any other thing, religious affiliation. So physical and digital infrastructure, intake form, trainings for providers and staff, and collection of SOGI data, which is really part of the intake form. So the sexual orientation and gender identity data, which is important for your own personal reasons and as well for kind of national data collection. The more and more we start collecting this data, and it can start being amalgamated to find trends, that's how we make policy change. But we need data to make policy change. We need data to show, hey, there are these disparities. Hey, these numbers are much larger than we thought they were. Hey, there's a lot more gay men in this community, or there's a lot more transgender or non-binary people over here. How do we put together programs to help them? How do we put together resources? Well, we need numbers to do that.
Right.
So those are the big areas. And they're not as daunting as they sound. And the biggest thing is buy-in from your clinic, getting everyone to be on board about it. And once they are,
and actually that was going to be my follow-up. How do you? Because I feel like a lot. I assume that a lot of much of the barrier to adopting the model comes from just like a lack of education, a proper education and awareness, right? But another part of it probably comes from just the lack of willingness and desire to do so for whatever reason. It could be cultural, it could be religious, the state that you live in, the geography that you live in. So how do you get the buy-in in those circumstances?
So part of it is about talking about lived experience. That's very important. Some of the trainings I used came from the National LGBTQIA+ Health Education Center. And they have wonderful videos of people talking about lived experience, showing how healthcare can be traumatic and how we can make a difference to make it not so traumatic. Having people come into your clinic and talk to you as a human to human about how, you know, it would be so nice to have a safe place to come to. And I think by and large, a majority of people are cool with it, are on the level.
Right.
And it's actually the minority that isn't, but the fear of people are afraid to admit to each other that it's okay. But once, for example, in our clinic, it became the cultural norm and the expectation. These are the trainings. This is what we're going to be doing here. The one or two people that weren't on board, well, the rest of the clinic kind of let them know it wasn't okay anymore. You know, you kind of use each other to reinforce the cultural norms. Then also, when you're hiring new people, you hire right out the bat and you tell them, this is what this clinic is about. And this is the expectation here. So the new people, they don't know any different, right? Which is excellent. But those, you know, the buy-in, it takes being consistent and gentle, because being too abrupt makes people push back, right? So having grace, being gentle, being persistent though, and also communicating. Right? Call it right out. I see you're uncomfortable with this. Let's talk about it. Let's talk about it. What's going on? You know, which takes courage, right? To have to do that. You might have worked with somebody for 20 years and then all of a sudden, right? And it's hard. It's hard. We're in a pretty conservative area of New Hampshire, and all of a sudden, I'm asking my front desk to ask our patients what their sexual orientation and gender identity is. And it's totally taboo to a lot of these people to talk about, right?
Right.
All of a sudden,
Right,
I'm asking them
right.
to ask and have to confront about patients that are like, what are you asking me for? Don't I look like a man? And, you know, all kinds of stuff, that pushback we got at the beginning.
Mhm.
But it becomes second nature after a while. And they eventually do figure out that it's the cultural norm, and now nobody has a problem with it. It just is a little bit bumpy
Right.
at the beginning usually, and then it's okay.
Right. Yeah, no, absolutely. And like, back to your point around consistency and just making people normalizing it, right?
Yep.
And so that's what it's about. I want to be mindful of time because I know we're about 5 minutes to the top of the hour. I'll just ask one more question to each of you, and then I'll go into the chat to look at the questions being asked by the audience. So for you, Dr. Corby, what advice or any particular resources that are top of mind to you would you recommend for healthcare professionals interested in learning more about LGBT healthcare?
Yeah, so I already mentioned them before. The National LGBTQIA plus Health Education Center is a wealth of knowledge. It's all free. There's a lot of CMEs that you can get from it. I mean, they have lectures, they have webinars, they have videos, they have audio, they have print material. It's awesome, and there's so much. All of my trainings for my staff came from that, with the exception of one microaggression training that I got from the American Psychological Association. But other than that, they're a wealth of knowledge, and they have sample intake forms, and they have pamphlets that you can print out and give to your patients. They're amazing. So they're a really good one. WPATH is another great one. They have guidelines on care, published guidelines, specifically transgender care, hormone care, every gender affirming care. They're wonderful. I'm always happy to be a resource to people, and you're welcome to give my email address out to anybody that wants to talk more and is interested in helping make their clinic, large or small organization. I'm happy to talk to anybody about the changes that can be done. Yeah, those are the three big ones.
Perfect. Thank you so much. And Cesar, what advice would you give to others in situations similar to yours on how to navigate their discussions around transitioning with healthcare providers?
I'd say pick your battles, and remember that people project. People project a lot, and what they say is a reflection of their own beliefs rather than a reflection of who you are as a person. And after it took me a long time and a lot of struggle to realize that I would take everything that somebody had to said and I would take it as a truth, and it would hurt. And when I stopped taking people's words as a reflection of myself, you know, once you become strong with yourself, then you could weather any storm. You just have to stay true to yourself, and you know, there's always going to be a hard moment, and it's always okay to take the time to feel things out and cry if you need to cry, be mad if you need to be mad, but tomorrow's another day, and you have tomorrow's another day in the rest of your life. That's
very well said. No, thank you for that. Okay, so I'll just proceed to the chat. There's a couple of questions I see here. One from Leslie. So she's saying, I'm curious about Dr. Corby's perspective on sexual orientation and gender identity data collection. There's a big push to collect that data widely in California right now. And while it's meant to be able to measure and report disparities, it also outs people in their medical records, especially in small towns. So would be curious to hear your perspective, Dr. Corby, and Cesar as well. Yeah,
so this was a problem for us too, because at the beginning, we didn't have a very advanced EMR. And, you know, we thought, okay, we're going to put it we're going to have it so that it's right at the top of the page. And then we realized when that encounter gets sealed, if we're referring someone to, I don't know, a GI doctor or a dermatologist or whatever, that encounter, the whole thing goes. And then all of a sudden we're outing them to another provider. We didn't actually do it. We thought it through first. But we thought, okay, this isn't going to work. So for ours, we have a confidential information section of the chart. We have a part that pops up when somebody signs in that tells what their preferred name and correct pronouns are. And so that gets written at the top of the chart when they walk in, and everything else is kept in confidential information, unless the patient has told us, I am totally out, go for it, right? So that confidential information section does not go with the chart when, for example, someone requests their records. Other charts like Epic, I think Athena, I'm not sure about eClinical, and there's so many others. They have a banner at the top of the chart that you can include correct name, pronouns, things like that, that also doesn't go with the chart, or you can work with settings so that if you are sending something that it would not go with it. But you have to be really careful, and you have to look into your own facility settings to make sure that those things are being thought of. Depending on how many patients you have, you may have to literally go back to good old whiteout or literally redact things. You have to be very careful about the information that you're being trusted with. That being said, if we continue contributing to the taboo by not collecting this information, we're never going to see policy change. We're never going to see demographic changes, because we're not going to have the data to support that these minorities are growing, right? And they're not going, they're getting larger and larger. I mean, when I started my doctoral work, for example, the estimate of the adult population, LGBTQIA plus, was like 4.5% or something. By the time I finished it, it was like 7.1%. So, that was over just a few years difference. So people are recognizing what they are more. They're communicating it, at least anonymously in surveys, right? The population is getting larger and larger. So I think it's important that we find ways, and that you look at your individual EMRs on how to make those changes. But you're absolutely right. You have to be really careful to safeguard their identities.
Absolutely. Cesar, how do you feel about this as a patient?
I think any information, the spread of information is important, like particularly, people, as we've been saying all along, need to be informed. And, I am not too informed about the infrastructure, healthcare infrastructure specifics on how that's going to work out. But as long as people's information are secure and they have the ability to, know who it's being sent to, I think information is important. Information is power, and that's how we empower one another and disenfranchised communities.
Absolutely. And just one last question, because I know we're just over now, but for Dr. Corby, have you noticed patients being more reluctant to seek gender affirming care given the current political climate? And what can providers and organizations do to ensure patient rights are protected through policy and advocacy?
All that in 2 minutes? I haven't personally seen people being hesitant. I've seen people be more in a rush to do it, because before they're afraid that they won't be able to. So that being said, people that feel that they are ready to transition, they're ready to transition, right? Like, it's not like, oh, I'll wait till next year, or like, when they're ready, they're ready. So I'm not seeing a reluctance, but I am seeing more fear, right? I am seeing more trepidation. So I'm also seeing a lot of beautiful courage, in people that are being true to themselves regardless. And absolutely, policy advocacy is so important. If people feel that they have any level of expertise to be able to speak intelligently on these topics, they should be expert witnesses. They should give testimony. They should do written testimony. They should do verbal, video testimony. Speak up, become a part of it. The more voices that we have, the more we'll realize that it's not so taboo, and it's everywhere. It's everywhere. We are everywhere, right? We are everywhere. And we just need to start showing people that if we have the courage to do it. It's scary in some parts of the country to do that. Absolutely. I'm not diminishing that, but strength in numbers, and written testimony doesn't require you getting up and speaking in front of people. It's a great way to start. Things like that. Little bits of advocacy are so important, and they do not go unnoticed.
Yeah, absolutely. Well, thank you so much to both of you. I really appreciate the time that you've given us. Both of your perspectives were very insightful. And I want to thank NALHE Tri-State and my fellow board members within the chapter for giving light to this critical topic. I hope you all found it to be informative and helpful. And to stay in touch with us at NALHE, for anyone curious, you can look us up on Instagram, Twitter, LinkedIn. You have our social handles there, or send us an email. But yeah, again, thank you so much both for your time. Really, really appreciate it, and it was a great conversation.
It was my pleasure. Thank you so much.
Yeah, thank you for having me.
Thank you, everyone. Of course. Have a good evening.
Bye-bye.